Cerebral sinovenous thrombosis. Cerebral venous drainage occurs via the cerebral sinovenous system. The superficial system, such as cortical veins and the superior sagittal sinus, and the deep system, such as internal cerebral veins, straight sinus, they converge at the torcula. Then it exits the cranial vault via the paired transverse and the sigmoid sinuses and the jugular veins. In cerebral sinovenous thrombosis, thrombotic occlusion of this venous structure can create regional or diffuse increased intracranial pressure, cerebral edema, and in around 50% of cases, venous infarction or hemorrhage. Cerebral sinovenous thrombosis may be more common in children than adults, and the risk is greatest in the neonatal period. Prothrombotic states associated with childhood cerebral sinovenous thrombosis include inherited conditions such as prothrombin gene mutation, acquired condition and the prothrombotic medication such as antiphospholipid antibodies, asparaginase, oral contraceptives, even common childhood illness such as otitis media, iron deficiency anemia, and dehydration, and systemic disease associated with increased risk of cerebral sinovenous thrombosis include leukemia, IBD, and the nephrotic syndrome. Head and the neck disorder can directly involve cerebral venous and the sinus, thereby causing cerebral sinovenous thrombosis, such as common infections, meningitis, otitis media, mastoiditis, which can cause septic thrombophlebitis of venous channels. Cerebral sinovenous thrombosis can complicate head trauma, especially in veins adjacent to skull fractures. And the neurosurgical procedures in proximity to cerebral venous structures may also lead to injury and cerebral sinovenous thrombosis. Clinical presentations are typically gradual, variable, and non-specific compared to arterial ischemic stroke. Neonates often present with encephalopathy and a seizure. Children may present with symptoms mimicking idiopathic intracranial hypertension, including progressive headache, papilledema, diplopia secondary to the sixth cranial nerve palsy, or with acute focal deficits. Seizure, lethargy, and confusion are also common. Either contrast CT venography or MR venography is necessary to demonstrate filling defects in the cerebral venous system. Otherwise, non-enhanced CT is insensitive in detecting cerebral sinovenous thrombosis. MR offers superior parenchymal imaging compared with CT, so MR venography is preferred. When we came to treatment, at initial diagnosis, supportive intervention include management of infection, detection and the treatment of seizure, neuroprotective measures such as normothermia, normotension, normovolemia, normoglycemia. The second part of management is treatment of the clot. Anticoagulation therapy plays an important role in childhood cerebral sinovenous treatment. Anticoagulation with unfractionated or low molecular weight heparin. In most children, later changed to vitamin K antagonist or warfarin. And treatment is usually planned for 6 months, but shorter treatment duration up to 3 months is recommended in neonates. The presence of hemorrhagic venous infarct is not an absolute contraindication. Children with persistent risk factors may require prophylactic long-term anticoagulation. The third is treatment of the sequelae of the clot. Compressive optic neuropathy secondary to prolonged ICP can lead to permanent visual loss. So this needs following a child with signs of increased ICP, and early management may prevent this. Treatment directed at reducing ICP such as acetazolamide, serial LP may be required. Most neurologic morbidities suffered by those incurring venous infarction. And as all neurologic problems, comprehensive neurorehabilitation program is required. Thank you for watching.